So for those that are just joining, let me just tell you the agenda for today for our Learning Collaborative. So I'm going to talk about transitioning care for youth with epilepsy. This is the didactic portion of our afternoon meeting. And then after that, we're going to try to get some feedback about how seizure screen implementation is going and try to see how we can support you to make that more successful in your practices. Some of the providers online have already given me a little feedback and may need to tune out early. So feel free to do that. And of those who can stay on, I would be really appreciative. That would be terrific. As an introduction to talking about transitioning, however, you probably in your inbox just got an email from me with a survey, and I'll talk about that in this talk. The goal is for us to determine where you all are in your practices with setting up transitioning care programs. And just so you don't think that the bar is too high, at Boston Medical Center, and we're the leaders for this, we are at the lowest level too, okay? So don't feel like, oh my goodness, my practice is a level 1. We're at the lowest level. Our job over the next couple of years is to work with you and teach as much as we can about transitioning youth with epilepsy and help you around doing something for transitioning in your practices. So as you fill it out, if you think, oh my goodness, this doesn't look good, don't worry about it. That's where we all are, okay? Great, so let's talk a little bit about, and this is really an introduction. It's truly just meant to be a quick overview for you. Okay, so I lose that, Christina. It's just the way it works. I think it's in presenter mode. Okay, great. And everyone can hear me okay?
Mm-hmm. So sorry about that, everyone. PowerPoint has decided to upgrade.
Oh, right at the minute.
Yeah. Oh, it's up and going now. Okay.
Sorry. Just love technology sometimes. Let's see. Can you see it now? Can you see a screen that says an introduction to transitioning care for young adults with epilepsy?
Yes.
Everyone can. Wonderful. Okay. So the objectives for today are to understand the differences between transitioning care and transfer of care. The second goal is to become familiar with some of the challenges in transferring youth with epilepsy to adult-oriented care. To become aware of why that's important, why we need to transition youth. I'll talk about the 6 core elements of transitioning, which comes from the national organization called Got Transition. And I will try to familiarize you or refamiliarize you with that particular organization and the resources on their website. And just so you know, they are one of our stakeholders in this project and work along very closely with the Maternal Child Health Bureau and the AAP in really implementing the 6 core elements of transition across practices. So what is transition and what is transfer? So let's start with transition. So transition is a process that begins in early adolescence. It doesn't happen just at adulthood. And it's really a preparation process for the youth to become as independent as possible in understanding how to manage their illness and how to navigate the healthcare system. And I say as independent as possible because in our patient mix, especially those with epilepsy, we have a lot of patients who have very severe learning disabilities, cognitive disorders, or in fact, intellectual disability. And so they may not be completely independent, but they might be able to navigate some of it on their own. And then we develop a plan with the patient and their family, the pediatric and the adult healthcare teams to really allow for a successful transition to adult-oriented care. A transfer at its best is really a formal handoff of information from a pediatric care provider to an adult care provider when the patient reaches adulthood. And at its worst, we've all seen this happen just because of time constraints. It's simply referral to an adult care provider and a phone number without actually a formal handoff. And I think it's pretty obvious that transitioning is much better for the patient and family. So patients' and parents' reaction to transitioning, as you can imagine, is pretty scary for them. It's a time of upheaval. It's a big change, and they've built a relationship with the pediatric providers and what's going to happen when that person becomes an adulthood and is making some of the decisions for themselves. There's a lot of fear about trust, Can I trust that the adult provider will make the best decisions in the interest of my adult child? There's a lot of confusion. What will happen when I go to the other side? It feels like a big black hole. They may feel abandoned. They've developed this incredible, sorry, I have a fax machine that you can just stop it, that comes into this office. But they feel abandoned. They've developed this amazing relationship over 18, 22 plus years with the pediatric provider. And then suddenly they're going to a new place. And for many of us, I think that's the hard part about being pediatricians, is we too don't want to abandon them. We feel a commitment almost as if they were our own. Very stressful time. And interestingly, there have been studies that have shown that parents rate the stress of transitioning to the time that their child was first diagnosed with intellectual disability. So I think it's even more upsetting if you have an adult child who is not able to fully make decisions for themselves. So what does good transitional care look like? Well, the goal is to provide uninterrupted care that optimizes the patient's health and maximizes their quality of life. What about the need? There are 18 million young adults in this country, 18 to 21 years of age, and approximately a quarter of them have chronic health conditions that will need to eventually receive adult-oriented care. Those 18 to 25 have the highest ER use and are likely to report no healthcare visits in the last 12 months. And most health providers feel that they lack a systematic way to support youth and families in transitioning from pediatric to adult care. So why transition? It sounds like that's a terrible thing in many ways, so why do it? Well, first of all, it's a rite of passage. And just like you get your driver's license, just like you can get an ID when you're of age, whether you have an intellectual disability or not, you may want to actually be in an adult practice. Some pediatric hospitals or practices may not be accredited, so at some point it's really a dead stop. They actually do have to transfer. Practice not be able to accommodate. You might have so many patients flowing in your door, you can't possibly keep them beyond 22. And then if they were to get accepted because they're an inpatient, the pediatric ward at some point may stop being able to care for that patient and they'll have to go to a new foreign place. And then they may develop problems not usually treated by pediatricians. So as a child neurologist, I feel pretty comfortable dealing with most neurology, but once my patients start having heart attacks, it makes me pretty nervous. And we all sort of have those things that we don't feel that we see enough to really be able to handle. What are some challenges transitioning youth with epilepsy in particular? So first of all, epilepsy isn't a single disease. It has many, many causes, and so there's a huge spectrum. So unlike diabetes, which is a single disease, you probably have a check number of things that you need to do. With epilepsy, you have to think a lot about what was the cause and what are the other comorbidities that come with the epilepsy when you're thinking about transitioning, because it may not just be that they need to transition for their primary care and their neurologist, but maybe they also need a gastroenterologist, they need a rehabilitation medicine specialist, they need somebody who does behavioral medicine. So it's really a huge undertaking. And as I mentioned, the comorbid conditions also influence it, because what about how can that person make decisions for themselves? Maybe they have overlapping developmental and cognitive disabilities. Does guardianship need to be established? What supports need to be in place? Or maybe they don't have a cognitive disability or developmental disability, but they have mental health issues. That too can really interfere. Mental health problems in people with epilepsy is very high. Somewhere in the order of a third have some type of emotional or behavioral health need. And then driving. So maybe you're of normal intelligence, but you have frequent enough seizures that you can't drive. So that means you always have to take somebody in tow with you, potentially somebody who wants to kind of take over their space. And there tends to be more input for that reason from folks other than the actual patient themselves. There was an interesting survey done for comfort of providers caring for patients with epilepsy. And what they did is they surveyed adult neurologists, adult epileptologists, pediatric neurologists, and then pediatric epilepsy specialists to say, how comfortable do you feel caring for this particular patient population with epilepsy. For patients with generalized epilepsy, no intellectual disability, an example of this would be a common epilepsy syndrome like juvenile myoclonic epilepsy. Pretty much everyone felt comfortable right across the board. So although it starts in teenagers, it continues on into adulthood. There's no comorbid conditions really that come with it. So pretty much everyone felt pretty comfortable looking at this line here. When you look at cortical malformation, it really drops. So if you have a developmental abnormality of brain, the adult neurologist, only about a third felt comfortable caring for this patient population. 3/4 of adult epileptologists felt comfortable, very different from the pediatric epileptologists and neurologists who this is part of their common practice. For the epileptic encephalopathy patient, this would be someone, for example, that has Lennox-Gastaut syndrome. These are kids who commonly have developmental delays discovered early in life, who go on to have multiple seizure types that remain refractory and continue on into adulthood. And as you can see, very small, 10% of adult neurologists feel comfortable doing this. About a half of adult epileptologists. And of course, not perfect in the PD world because these are hard patients to take care of, but there's a clear difference between these two. And then once you get down to intellectual disability or autism, I think the numbers really stand out here, that very few really feel comfortable taking care of that population, so making it very hard to transfer care. A lot of the slides that I'm about to show you actually come from the gut transition site, and one of their key people there is Dr. Patience White. She is an adult and pediatric rheumatologist and has done a lot of the work that you'll find on that site around transitioning. So you'll see a little notation of gut transition of the slides that actually came from her. You can also find this on the HRSA site as well. So if you haven't been to gut transition, and I truly hadn't been there until I started to look at this project, it's really an amazing wealth of information. It's a great place to refer your patients who are in that transitioning site. It's also great for your providers to really look for resources. So when you transition to adult-oriented care, that doesn't always mean that you actually have to change new locations. So many of you work, for example, at sites where you have family physicians. And so the family provider might be able to see the patient from birth to the end of their lifespan. And so they're not really transferring care, but they are doing an adult approach to care, where questions are being directed towards the patient and the patient is expected to navigate the system and to have knowledge about their medical illness. And so one thing that can happen is if you're a purely pediatric practice, is you will transition from a pediatric to an adult healthcare provider. That also requires a transfer of care. Like the family physician, where they can transition to an adult approach to healthcare without changing providers, med-peds specialists would be in that category, and to some degree, child neurologists. There is a time where you eventually feel uncomfortable, like I said, especially once they start to have myocardial infarction and sometimes even stroke, but lots of other adult complications we feel the need to transfer. But we can support them a little bit longer because we've also been trained in adult neurology. There are 6 core elements to transition. I'll walk you through these. The first is to develop a transition policy. The second is really to have a system so you can track the young adult through the whole transition process, as well as through transfer if transfer is needed. There is an assessment of the youth for transition readiness. I'll explain that. There's transition planning. What's going to happen at 18? What's going to happen at 22? Will they stay? Will they go? Who will they see? What do they need to have in place for that to be successful? Then if they do need to actually change providers or locations of care, there's a transfer of care that happens. And then the 6th step is really when you're assessing transition completion. Has it been successful? And having remain as contact with the adult providers. So we are in the process of developing our own transition guideline for the Epilepsy Center for the specialty care. If you are interested in developing your transition policy, if you don't have one, there are nice examples that are on the Got Transition site where you could just kind of modify it and just make it your own based on what they've given as a suggestion here. So step 2, as I mentioned, is transition tracking. This is a little bit more difficult. Basically, you have to establish criteria for identifying who's ready for transitioning, and then have some way to track them, whether it be a database or a registry, which isn't always easy. That's labor intensive and requires some technology, but that would be the goal. It's definitely our goal here at the Epilepsy Center. And basically you want to get a sense of where are they in the transition process and basically incorporate these into your care practice. So transition readiness is something we're going to be doing here at the Epilepsy Center. So we're going to be screening our youth starting around age 14 for transition readiness using what's called the TRACK score. I'm curious, has anyone ever done transition readiness assessment who's online right now? No.
No.
So it's a pretty easy screen. It can be self-administered. We're going to be sending it to our own patients. And basically there are really, let's see if I can blow this up. And you can bill for it, as Christina points me out. I want to try to magnify this. I don't know if this is going to work. So I think so. I'm learning new tools here. So as you can see, you want to basically evaluate how important is it to you to prepare for change to an adult doctor before age 22, and how confident do you feel? And then basically there are a series of questions that are about how much do I know about my own health condition? And then there are questions about navigation. And this can be totally self-administered. So then the next stage, which is step 4 of the gut transition, is to plan with the youth and families. So we don't necessarily dictate to patients' families what they should do. We develop a plan. We want to determine who is actually going to be giving the care when they turn into an adult. And then we try to figure out, well, what supports are going to be needed for them to transition successfully to adult-oriented care. They need supported decision-making. Does guardianship need to be established? Do they need special communication needs? So I actually have a patient who has both cerebral palsy and has epilepsy, who is of normal intelligence, but is so dysarthric that part of the reason her mother comes to the sessions is I don't understand her. She does have a communication device, but it's very slow. And so we're still figuring out how we can make her as independent as possible and allow her to really receive adult-oriented care without her mother in the room. But this comes up for many of our patients. And then we want to share the plan with the youth and the family and whoever else is going to be part of their team. The transfer of care may or may not happen within your own health centers. And here we sort of are developing a guideline to help decide how that actually happens and who it needs to happen with. But the goal would be is that it's clear to the patient family when it's going to happen, what's going to happen, and that also on the adult side, whoever the adult provider of care is going to be, that they are fully up to speed, have hopefully been introduced to the patient, and that you will actually remain on as a consultant as needed until that process is successful, especially where there may be holes in communication. And then the last step, we're almost there, is transfer completion. And this is we want to determine if the patient is really integrated well into the adult practice. So our way of assessing this for our own group is going to be not only that they actually had an appointment with the adult provider, but also that they have a follow-up appointment and they actually complete the follow-up appointment. It's important to get feedback from the family and then offer again here to remain on as a consultant, because as you saw with that slide when I showed you comfort of adult providers with people who have epilepsy, especially if there's developmental disabilities, really is low. And if you remain on as a consultant, then may be more willing to help take on that patient where you can remain as the pediatric expert on developmental conditions. So any questions to this point? I want